Hi, everyone. Good morning. I'm Ann Richmond, the Executive Director of the MQ Foundation. Thank you so much for joining us for our inaugural webinar, where we'll profile MQ-funded researchers. I am delighted to see so many familiar and new names on our participant list. Your interest and engagement in the latest mental health studies affirms our mission to break new ground in mental health science by funding promising cutting-edge research in the field. I want to take a moment to thank the MQ Foundation Board of Trustees. Their commitment to the foundation has directed millions of dollars to promising research. Our goal is to help billions of individuals affected by mental health conditions across the globe. And to accomplish this, MQF and our partner, MQ Mental Health Research in the UK, have invested $37 million in new research since 2013, which has subsequently attracted an additional $58 million from public and private sources, resulting in 32 new treatments. We are very proud of those stats. Investment in groundbreaking mental health research has never been more important. Nearly 1/2 of Americans will have a diagnosable mental illness in their lifetime, and most serious mental illnesses begin before the age of 25. Research is truly the only path towards effective treatments and diagnosis. And yet, as we all know, federal research funds are being slashed, and young scientists are being forced to cut their careers short before they've even started. While support for mental health research from organizations like the MQ Foundation cannot replace government funding cuts, it offers a secure and stable funding opportunity at this time. I'm honored now to introduce three of our board members, Catherine McNear, Hayden Horowitz, and Dr. Emily Holmes. They have been instrumental to MQ's progress, and I am very grateful to them. I thought it would be fitting to start today's program by hearing from Catherine. Thanks so much, Catherine, and I'll let you take it from here.
Thank you, Anne, and thank you to everyone for joining us this morning. As Anne mentioned, I wanted to share with you why I got involved with MQF and the reason why I am dedicated to mental health research. When my husband John and I met about 30 years ago, one of the many things we bonded on initially was that we had both grown up in families touched by bipolar disorder. And as children, we navigated the unpredictable waters of living with loved ones battling this challenging condition. The impact on our childhoods was profound, shaping our understanding of mental health and the urgent need for better solutions. Tragically, several years ago, John's sister lost her battle with bipolar disorder and took her own life. This devastating loss left an indelible mark on our family and reinforced our commitment to try to make a difference. Not long after this difficult time, we met with Anne and the team at MQ and felt very strongly that together we could make an impact and potentially help to spare others from the same anguish. To honor my sister-in-law's memory, John and I funded an MQ research fellowship last year. This fellowship has enabled Dr. Alex Lussier at Harvard to investigate how childhood depression interacts with genetic factors that might lead to suicide later in life. We know that Alex's research, along with the research of so many others supported by MQF, will guide us to better outcomes for future generations. Two such investigators are here with us today, and I know you're eager to hear from them. But before we get to our panel, I wanted to introduce my fellow board member, Hayden Horowitz, to kick off today's program.
Thank you, Catherine, and good morning to everyone. I was introduced to MQ Foundation last year by our board chair, John Herman, and the organization's mission to promote important research to better understand and treat mental illness resonated with me immediately. I've experienced firsthand the challenges of mental illness in both my immediate and extended family, spanning ADHD, anxiety, depression, and bipolar disorder. These challenges have brought tremendous stress and pain to my family, and for this reason, I committed to support the MQ Foundation with the hope that we can find preventive measures or treatments that will spare others in the future. I'm delighted to kick off our panel discussion featuring two MQ research fellows, Doctors Zachary Cohen and Marisa Marraccini. Their conversation will be led by my fellow board member, Dr. Emily Holmes. Emily is a world-renowned clinical psychologist and neuroscientist at Uppsala University, having previously been at Oxford and Cambridge. She is internationally known for her pioneering research on mental imagery and its role in emotional disorders like PTSD and depression. Her work stands out for how she translates cognitive science into practical tools to prevent and treat mental illness, often drawing from techniques as diverse as computer games and mental imagery interventions. Dr. Holmes is the recipient of many accolades for her work, including the American Psychological Association's Award for Distinguished Scientific Early Career Contributions to Psychology. She was instrumental to the founding of our partner organization, MQ Mental Health Research, and has been a member of the MQ Foundation's board since 2022. Please join me in welcoming Dr. Holmes to lead our discussion this morning.
Thank you, Hayden, for that lovely introduction. And it's such a pleasure to be joining you all this morning. I just wanted to pick up from what Catherine and Hayden both said and express as well, from my point of view, why it's such an exciting and important time for us to all be putting efforts into mental health science. And if we think about other areas of health and medicine, some decades ago, we felt hopeless about cancer and what to do. And then there was a research investment. And that research investment pays dividends in terms of improved treatments and ways to reach people. The same for heart disease, the same for many, many other areas. But mental health is one of the few areas that has not yet seen those large investments. But now we have the right kind of science and tools, which we'll be talking about today, which means we can really progress and go forwards. So I'm really delighted to share two people as research who MQ has helped fund, and I'll tell you a little bit about them. The first is Marisa Marraccini, and she is Associate Professor of School Psychology in the School of Education at the University of North Carolina, Chapel Hill. She specializes in promoting student mental health and preventing youth suicide, for example, in children. After completing her PhD in school psychology at the University of Rhode Island, she did advanced training in suicide research techniques through her postdoctoral fellowship work. And then she's received a variety of funding. In particular, we're very, very proud that she's in the third year of an MQ fellowship, where she's been leading research on testing novel approaches to help with youth suicide prevention. And what I personally love about Marisa's work is her ability to capture on the technologies that we know inspire and are very interesting to young people today, and yet use that to where they are with the kind of compassion and humanness to understand what children and young people need. And that amazing science compassion combination, Marisa, is fantastic. So if you want to just say a little bit about the topic of your research for a minute, and then I'll introduce Zach, and then we'll get into the Q&A.
Yeah, thank you so much, Emily. I have been developing and studying a virtual reality intervention that we designed in collaboration with teens who have struggled with suicide-related thoughts and behaviors that allows kids to learn cognitive behavioral therapy skills that are evidence-based in a virtual reality headset, and then practice using those skills in a life experience while they're in the hospital before they return out to community settings.
That's fantastic. Thank you, Marisa. So I'm going to introduce Zach now, and then Marisa, you and I are going to talk a bit more. So Zachary Cohen is Assistant Professor at the Department of Psychology at the University of Arizona, and he directs what's called the Personalized Treatments Lab. And can I make that clear for those of you in the audience? I think you probably all know there's not a one size fits all. Often we need to tailor a treatment to a particular individual, and we need to personalize it. And that's exactly the kind of thing Zach studies. So he asks questions like, how and for whom the treatment works? And he uses data-driven approaches, advancing tools like machine learning to pursue these questions and creating really innovative new types of therapy. The latest one's called rain frog. We'll find more about that later, Zach. And what I really love about Zach's research is this amazing ability to understand what it is to be a clinician, to have seen what it is to work in an area like depression and know we need to tailor it, and then to have a passion for maths and digital science. So you're truly interdisciplinary as a scientist, pulling all of that together. and I followed your work, but had the privilege to for some times. And just to correct the record, we've actually funded Zach really early on through a program called Impact in MQ, and we'll be talking more about that fruit of that work in a bit. So, Zach, if you could just say a little bit about your topic.
Thank you, Emily, and I've been inspired by your work for even longer. The work I do, as you mentioned, grew out of an interest of understanding why certain people respond to certain treatments and why others don't, and how can we use our knowledge about that to improve treatment, to improve outcomes for people struggling with mental illness. And so that work for a long time focused on data-driven approaches where we leverage existing clinical trial data sets or large naturalistic data sets to identify factors that predict that certain people are going to respond better to certain treatments and transform those using, as you mentioned, statistical algorithms into clinician or patient-centered clinical decision support tools. So things that can, when you're trying to pick which treatment to start with, help you identify the one that's going to be best for you. That work has evolved into studying digital treatments, which are another thing in the arsenal of how we can combat mental illness, and a really important tool in bridging the divide, that gap in access to care because of their scalability. But kind of one of the big issues is how do we make those tools personalized? How do we make them like a clinician would so that they're more effective? And so now we're trying to use that science of precision medicine to make those digital treatments more effective.
And that's been so important in other areas of medicine, like cancer for precision medicine and so on and so forth. So I think it's just wonderful. We're now just starting to bring that into our field, improving mental health resources for many more people than we can currently reach today. So it's wonderful to have the two of you. In a way, it's like, Zach, you have the big picture, how we're going to be tailoring, but I want to start with Marisa's work with youth. As Anne said in her introduction, for a lot of people, we now know that early signs of mental illness and distress start very early on, below the age of 25, and for those still at school. And your work's really groundbreaking, because what you're trying to do is, rather than fit the child into the existing systems, you're trying to invent tools which allow us to reach the child or the young person who needs the help. And digitalization has allowed you to do that. So your acronym's a bit of a mouthful, so I'm going to spell it out for the audience. It's PRESR, and what that stands for is Practice Experiences for School Reintegration. Marisa, over to you. Share us a little bit about what it is you're working on and what you're doing right now with this.
Yeah. So, I mean, this intervention really started with working with kids in schools and seeing a gap in how we support kids after they've had a mental health crisis, a serious mental health crisis. And on the ground, I really struggled with supporting kids once we identified kids with risk and referred them to outpatient care or to inpatient care. And when they came back to school, I was trained as a school psychologist. And so I really have a school lens in everything I do. And when they came back to schools, which is where the majority of kids are, the majority of their time, we didn't have the tools, the time, the resources, or sometimes the skills to really support kids who were continuing to recover. And, when we think about struggling with suicide-related thoughts and behaviors specifically, recovery is not necessarily linear. Kids don't necessarily come out of an inpatient setting or an acute treatment when they've had a crisis with the skills that they need to continue to engage in school and other community settings. And so that work was initially thinking about how to bridge communication across settings. I was really, really lucky to have some of my primary foundation from a partner of MQF, I think, American Foundation for Suicide Prevention, to engage in that work. And ultimately, it led me to realize that there's more we could do in the inpatient setting to prepare kids to return to schools.
So whilst they're in hospital.
While they're in the hospital, exactly.
Yeah,
So oftentimes the hospital is really focused on medication management and long-term planning once
yeah.
kids discharge. There's not a lot of opportunities for psychosocial interventions in a lot of the inpatient facilities where kids receive mental health treatment. But our teens who were working with us on this project really expressed a desire for more psychosocial supports while they're in the hospital before they returned to school.
And if I just dig into that a little bit, you talk about your teams involved in this. That one of the things your research is renowned for doing is involving people directly to ask them what they want and to work with what we call lived experience. Could you just touch on that a little bit?
Yeah, absolutely. I mean, I think, I always like to start by acknowledging that pretty much everything that I'm privileged to share out is based on what teens and families and professionals in the hospitals and schools have told me to do. So of course I'm, drawing from theory and evidence, and there are some constraints around this, but largely this work is based on what teens and families and providers have said that they need and want. Initially, our work was focused more traditionally qualitative research where we would ask people what they thought and then try to integrate that into our perspective and into our work. It evolved towards something called user-centered design, where we began to be more collaborative, and then all the way towards what MQ is funding right now, which is more participatory co-design, where we're actually meeting together regularly in groups with teens who have lived experience, who've struggled with suicide-related thoughts and behaviors, to make sure that we're building something that's meaningful to them.
And isn't that a fantastic way for science to advance, as it were, in a new direction? I think, as Anne said, something MQF's really promoting as well. So we actually work out with people what they need rather than the old-fashioned approach, which is sort of telling people what they needed. So that bringing back that lived experience work now to the research that you're doing and the new intervention. Can you tell us a little bit about how that intervention works?
Absolutely. Yeah. So it's a virtual reality intervention, which means kids are putting on a headset while they're in the
Okay.
hospital. And that is novel in and of itself when kids are in the hospital, because for those of you who don't know, kids lose access to their digital devices while they're hospitalized. And so having some sort of engagement with a digital technology by itself is kind of an exciting thing to do. But it's not a game. It is an intervention. And the way it works is there's a virtual avatar who serves as a coach. And the coach teaches kids evidence-based skills that could help them get through their day-to-day experiences when they leave the hospital. And this was key because when we initially designed this intervention, we were thinking of it more as augmenting clinician care, where the clinicians would teach the skills, and then we would enhance that with some VR work. But we found that really logistically, there aren't enough clinicians, or there isn't enough guarantee that there's going to be someone in the inpatient setting to really teach these skills well. So we built that into our intervention. The piece that makes our intervention a little bit different than other digital mental health interventions is that after kids learn their skill, they then go into a practice session, which mimics real life, which mimics sort of the daily stressors that we know they might face when they return to
In the
school.
virtual reality.
In the virtual
Yeah.
reality. Yeah.
So I guess virtual reality is really great at that because you can put the headset on and bang, go into that other world. So
Exactly.
is it like you're practicing that skill in the real world again?
It's like you're practicing that skill in the real world again. And what's awesome about this, as opposed to assigning homework and having kids go back into the hospital and try using the skill in real life,
Yeah.
is in the middle of it, when it gets pretty stressful, our coach jumps back in and it says, okay, let's do what we just practiced. So ultimately, we hope that kids will be more likely to use those skills when they're in real life.
It sounds like a really kind way of helping someone. So you're giving them skills before they've left the hospital rather than waiting them to leave and doing it later. And also, having done a little bit of work in hospitals myself, there's a lot of empty time. I mean, how do kids value the chance to actually get on with doing something whilst they're waiting there?
Yeah, absolutely. I think, all the hospitals look really different, but that is one thing that is a commonality across inpatient experiences is there is a whole day to fill for these kids, and there aren't always staff with clinical intensive training to fill that whole day, right? So no matter what, there are going to be these gaps where we want to offer engaging opportunities for kids to continue to work on their care.
And I'm just thinking about the sort of how the intervention goes forward. Is it possible to give us sort of a very practical example of a sort of skill? Because I know that in Zach's work, he's interested in skills and components of therapies is one of his maths questions. But in your work, what sort of just a sort of useful skill, what's the kind of thing that you might be able to teach a child whilst they're in hospital that ends up being useful? Because from my understanding of the suicide prevention literature, sometimes there's very simple skills, but they really need to learn them properly to stay safe. Can
Yeah,
you give us
yeah.
an example?
Yeah, and I'm really excited to hear about Zach's work because I think we could learn a lot from his work in terms of thinking about which skills to select. But a couple of the skills are cognitive restructuring, which is identifying negative or faulty thinking patterns and learning ways to question them and to perhaps replace them with healthier thoughts. And that is a hard thing to teach. It's a really complicated skill. And at the more basic level, one of the skills that we teach is kids identifying big feelings and thinking about and learning about and practicing how to handle them. So things that I expect we'll hear from Zach about around um, guided imagery, deep breathing, and things like that after learning what your emotion is and how intense it is.
Fantastic. So you've really broken new grounds. You're starting to do a treatment in the hospital. You've built the treatment around what both clinicians and the children themselves want to do. And you've also worked with in the technology to get this to work. What needs to happen next, do you think, for your research to get to reality?
Yeah, we still have a lot of steps to go. So I'm really excited to share that our pilot clinical trial, which means that we were just doing a smaller version of testing this intervention to see if it works. So we don't yet know if it works. But our pilot trial to show that we could do it, we could bring it into the hospital and test it with kids, was just published actually today. The paper is just released today.
Oh, that's fantastic timing. Congratulations. It's a real slog getting through to a publication. So that's brilliant, brilliant.
Yeah, absolutely. But on that note, the next step is a fully powered trial, meaning that we have enough kids to test it to determine if the intervention is effective or not.
And if I can just pull back for the audience a little bit here. So if you were to if you go into your pharmacy and get a medicine, you'd expect that medicine or that headache tablet to have been properly tested and been through clinical trials to check its safety and its efficacy and its effectiveness. And so what Marissa's stage of her research is, she's discovered the new technique. She's got it working, which is the really, really hard bit. But what we also are trying to do now in the new world of mental health science is properly check that these things work when you start to scale it up. And as part of that, learn from doing it, because you learn so much real world implementation. But that means a big research study. So you're talking about a randomized controlled trial next, Marissa, yeah?
Yeah, absolutely. That's the next step.
Brilliant. Well, and when you've got a pilot trial, you're ready to do that. So that's really exciting. And I'm sure we're all with you there, really hoping these next steps can happen soon. And looking to the future, how do you think that that other people might think or learn from your research?
Yeah, I mean,
I know that's a tough question because we're always
I think, a big learning for me professionally and my team is how important it is to think outside the box. I think it's really important to build from what previous researchers and existing clinical care is. And it's also just important to step outside of that for a little bit and wonder and be curious about what we're missing and what we could be, right? Because we bring these lenses to everything that we do. And I mean, that's one place where MQ has been actually particularly meaningful for me because there aren't always a lot of opportunities for you to kind of step to the side and do this kind of high risk, high reward, potentially valuable, but new research. And things like partnering with kids with lived experience in suicide, that's hard. It's really hard and it's really scary. And it's not always something that a lot of funders or other researchers want you to do, but it's incredibly important for prioritizing kids' voices. Things like bringing technology, virtual reality technology, into suicide prevention, intervention, and assessment. That's really hard and scary. And so a lot of times people will say, well, why wouldn't you start with something else? Why would you start with one of the highest risk outcomes? And to me, that's a sign that we need to do this work. We need to not forget about these kids. Like I got into this work because kids are showing up with suicidal thoughts and behaviors, and adults are scared of them. In schools, in other settings, it's scary to work with kids who are struggling with these thoughts. But they're kids, And they're so creative and they're so insightful and they're so important. And we need to not be scared of them. We need to lean into that and do this work. So I guess the big takeaway for other researchers from my perspective is to just keep kind of pushing the boundaries, but making sure you're going about this in a methodical, safe, and rigorous way.
I think that snapshot there of leaning in, meeting the kids with the beautiful science you do, and also the clinical wisdom as your time as a school psychologist, putting that together is such a rare combination, but a possible combination. And I think it is inspiring. What we need in mental health science is exactly this, going into new grounds and doing it in new ways. Marisa, we could talk for hours. I'm sure we'll do it after this seminar as well. But Zach, before I turn to you, I was wondering, did you want to ask Marisa anything? I could see you nodding away there.
I mean, so many
Yeah.
things.
You can have
I'll say
one
that-
question, and then we're going to talk about your research.
Yeah, I'll say that I've been very inspired learning all about the participatory work that you've done and the way you've so thoughtfully combined the evidence-based interventions and as you mentioned, theory and science with the lived experience and the co-design. And so I'm wondering, it's something that I'm attempting to integrate into our work, but at the very sort of beginning stages relative to the maturity of yours. And I was wondering, how do you balance those two things when you find them in tension, right? When you have, I do a lot of work in anxiety disorders, and one of the things that we have people do in psychological interventions for anxiety disorders is engage in something that they've been avoiding, which is often very difficult for people to do and not something that they would come to the table saying, I'm afraid of this thing. What I want to do is engage with it, right? But we know from the science that that is one of the things that's going to make them better. So how do you deal with tension of any sort when you encounter it between those two camps?
Yeah, that's such an important question because the reality is you can't just walk into a room and do exactly what people want you to do. We want to really value lived experience and partner with individuals with lived experience, but we also want to value science and the rich literature that we're building from. And so typically the way that works is acknowledging and being honest about where the parameters are that we have clear boundaries that we have to do this. So the conceptual framework is rigid in this way and flexible in this way. So let's work in the flexible areas. And then, of course, if you have concerns about the rigidity, because there are these classic interventions that are well accepted that we could go in and say, you can't change this, that are harmful to some people. So we don't want to be too rigid. So we still want to listen and try to see if we're missing something. But we also have to build from existing frameworks. And so your example, Zach, is perfect. Like going to a group of people and saying, what do you want to do? And not considering exposure to anxiety might not be the best approach. But talking about how we're trying to make this a little bit better and more engaging and more exciting for folks, how can we make this exposure experience better received is where you might want to start.
Yeah. And that's a fantastic example of the nitty-gritty you're seeing playing out here. I think that is when we have these ingredients of treatments, how do we get them to do the ones that are right? But also, how could one start to use leveraging lived experience behind the personalization account? So that for the small number of people something won't work for, we try and learn as quickly as possible, because just like other areas of medicine, that's what we have to learn to do. And I'm sure all of you in the audience have experienced that some treatments work for some people and not others. So thank you, Marisa. I'm going to turn to Zach now. And Zach, I'm going to start with a little bit of a quote from you. And I'm going to ask you if you want to follow up on it. And this was something that you wrote to Anne when we set up the board soon after that of MQF in November 2021. And Anne joined the team. And you wrote, I'll always think of MQ as the first group who believed in me and the work we're doing, and will be forever grateful for how your support helped launch my career. MQ's support has had an enormous impact on my work and the field more broadly, and I look forward to continuing to watch the great work being done both in the UK and the US MQ families. Please let me know if there's anything I can do of service. And of course, we have let you know, because you said, please can you come and do this webinar with us today. But what a lovely quote, Zach, and maybe tell us a little bit about your MQ journey. And because you did take, when I first read your grant proposals, you were doing really out the box high risk stuff. So tell us a little bit more about that.
Yeah, I think my master's thesis, where we published what we called the Personalized Advantage Index, which was one of the first attempts to use these statistical algorithms to predict which treatment is going to be best for whom. It was desk rejected by 9 journals before it finally got reviewed.
All the best papers are.
Yeah, one of the editors said, I think this could be, a groundbreaking, changing paper, but I'm afraid to publish it, and then rejected it. And MQ was really one of the only funders who was open to the idea of us being able to do what had been done in successfully in oncology and cancer treatment in mental health. And so they funded this work at a time that really people weren't supporting it. And in the time since, it's grown to be one of the major sort of foci of mental health is
Yeah.
precision treatment, personalized treatment.
Yeah, we're so proud of that groundbreaking work you did. And you're right. It's hard to imagine that, almost a decade ago, people were saying this was impossible and outrageous. And now it's like, of course, we should be doing this. So just to put it into sort of more everyday language, what the Personalized Advantage Index does is effectively look at the characteristics of someone going into a treatment, and rather than it just being into that individual treatment to say, oh, I think this person should get this treatment or that treatment, to tell us a little, just give us one example of how we can see further by simply doing the clever maths that you've done with some of the giants in our field too. So everyone's converted, and how that helps an individual person.
Yeah, so I'll give you one of the most exciting examples, which is work led by Jamie Delgadillo, a colleague who was involved in the second MQ funded project that we did, where he and his colleagues used a large database from the UK that looked at the outcomes of tens of thousands of people who had undergone low or high intensity treatment in psychological therapies. And they took the combination of this signal, so not one variable, but how does your history of chronic mental illness, how does your marital status, your age, your employment status, medical comorbidities, how do all of those things help us predict who's going to respond to low intensity treatment or who's not going to be likely to respond and should go directly to high intensity treatment? And in the UK, in a system that treats over 600,000 people a year, screens over 1 million people, what he and his colleagues were able to do is to use an algorithm that was developed using this sort of approach to help inform that shared decision process of who should start in low intensity and who should start in high intensity, and in a randomized prospective trial, meaning what they did was they took, it was over 1,000 people, and half of them were randomized to have treatment as usual, meaning the best standard of care. You come into treatment and the clinician uses their clinical wisdom in combination with the patient to say, I think this patient should go to high versus low intensity, and compared that to that same decision informed by the algorithm. And the people who got data-driven treatment actually had better outcomes. They had a higher remission and recovery rate. They had more sustained gains, right? And so it's actual prospective evidence that precision treatment can work in mental health. And it was the first trial to do that in psychological therapy. And
It's
that
so
grew out of work
exciting.
funded by MQ.
It's so exciting. And I think for all of us as clinicians or family members of or loved ones of people with mental, just speeding up getting to the right treatment. There's so much time wasted out there with people having to try things at sort of random schedules rather than actually knowing what's going to work for them. Zach, again, we could speak for hours. I want to just go straight into what you're working on now. For example, if you'd like to talk a little bit about Rainfrog and this kind of, not content with breaking one boundary, you're now on to breaking new other boundaries. So tell us a little bit about that, mindful of the time. So, yeah.
Yeah, so working with Dr. Michelle Krask and the Depression Grand Challenge at UCLA, we saw an opportunity to take this idea of personalized or precision treatment and scale its impact. Because as Marisa pointed out, there are not enough clinicians to address the mental health needs of the world's population. And so digital tools are one way in which we can scale that impact, but they're often not personalized. So what we did was we developed a whole ecosystem of therapy-based modules that deliver the tools and skills that we use when we do face-to-face treatment, but through a web interface, through a mobile app. And what that intervention can do is it can say, okay, somebody walks in the door and people are complex. They're not just somebody with depression or somebody who's dealing with social anxiety. They often present with a combination of different things. So somebody who comes in with PTSD.
That's the real world, right? It's not all in boxes. Yeah.
PTSD and depression and sleep. We know these things co-occur. What are you going to do? Are you going to give them a package of each? That's not efficient. That's not effective. How do you know what to give them? So this system does an assessment and picks the exact combination of modules that we think are going to be best for you. And it even goes beyond that. So we know that there are different types of sleep problems, right? People have trouble falling asleep, or people who wake up in the middle of the night, or people wake up too early and can't get back to sleep. And we have different interventions that are going to be effective for that. So how can we give you the exact thing that's going to be most effective for you? And now our work is even starting to incorporate things that, like passive sensing. So if you, instead of wanting to like fill out a sleep diary, we're able to say, I'd like to allow you to access the data from my watch, and that data could tell what type of sleep problem I'm having, and then in real time give me the intervention that's going to be most effective for me. That sort of thing is really scaling the impact and the effectiveness of our interventions.
And also it's accelerating psychological treatments into the digital world by using remote sensing, by using techniques, again, by going to where the people are rather than making them go and fill in lots of questionnaires, used to be in the old days. That gives real hope, this kind of research pioneering forwards. Absolutely fantastic.
And I loved hearing about the work that Marisa's doing with virtual reality and helping people who are struggling with mental illness practice and learn these skills in ways that are safe and ways that are going to make it more likely for them to integrate it into their lives. So I'm so excited to hear more about that work. We think about it in terms of the app and how that can take the therapy skills out of the sort of therapy room and into the real world. But the stuff with virtual reality, I think, is super exciting.
I think we need all of these different approaches. And presumably, as we sit here over the next 10 years, even more approaches are going to be evolving. And how do we, I think as scientists, it's what's really important is to always think, and I think you've both spoken about that, about the importance of theory. How is the principles and hypothesis to what we're doing working? And then how do you apply it with the evolving technology to meet the scale of needs? And I have to be a bit historical again. There was a day we didn't have drugs like penicillin. We didn't know what the structure of the molecule was, and we couldn't disseminate it. And then we had ways of breaking down that molecule, working out how to scale it up, and now we can reach people. And I really start with this kind of adventurous stuff that you're doing. It's not science fiction. We can start to understand how these components are reacting. And then by doing that, we can use the research to build better treatments. And I think what we need people listening to us and the community to know is this science is really worth it, because this is the route to go from the knowledge that you're doing to eventually getting this research out in the real world. So Zach, tell us what you're doing next. And then Marisa, I was going to ask you if you had a question for Zach before we go to some of the audience questions.
Yeah, there's a lot of things that I'm very excited about that I and my colleagues are working on. One recent finding that we had, I think, plays into some of the things that Marisa was talking about. When we have people learn these different therapy skills and practice them, when they're in a research study, they have the option of allowing us to use those data to better understand how treatment works and for whom it works. And when they allow us to use those data, we can learn really interesting things. So one example from an honors thesis of an undergraduate in my lab, Tanner Vallis, working with my graduate student, Nate Chukis, looked at the information that people give us when they're doing imaginal exposure for PTSD. So you're recounting the difficult, traumatic situation. Usually it's a memory that you've been avoiding, and really learning how to re-engage, how to not avoid, how to reprocess that traumatic memory. And what they were able to do is create a rating system that quantified the extent to which people were engaging with it emotionally, going into detail, that allowed us to categorize people into high, medium, and low engagers. And what we found is that people who did the imaginal exposure module had better outcomes than people who didn't do it. That's interesting. But
That is,
the
yeah.
quality of engagement actually predicted outcomes. So those who engaged at a high level, doing it the way that we would hope that they would do it, really accessing the emotion, going into detail, had big improvements in outcome. People who were moderate engagers had some improvements, and people who did the module but didn't really buy into the intervention, weren't able to engage completely, really had no meaningful gain. And so what we're now hoping to do is to train an algorithm that could rate that in real time, so that
Within
when
session.
somebody's doing the actual intervention, it could be a signal that says, hey, you just did it, but
Yeah.
how can we help you engage better? So we can turn those people who might go on to not experience improvement into actual success stories.
What a lovely way to make a particular therapy session more effective. That sounds absolutely magical. Brilliant. Marisa, question for you, and then we're going to go to something in the chat as well.
Zach, it's perfect that you were just talking about engagement, because that is what I was going to ask you about. I believe that I've read that y'all have had some great success with sustained engagement, and I know that that is one of the number one challenges we have with digital mental health interventions. There's a good first time use, and then engagement falls off. Do you have any thoughts on how we can sustain engagement in these interventions?
Yeah, I think that's a great point you're raising. And I think it comes back to the work that you're doing. So the lived experience, the co-design. So when we went to develop this intervention, working with our collaborators in academia, we pulled their clinical content, but then we worked with the actual stakeholders. So again, work led by Michelle Krask at the Depression Grand Challenge. We worked with people at East Los Angeles Community College who were student advocates, who were people with lived experience, who were the actual target audience. And we asked them, what do you need? What are the things that don't work about the interventions that you've had? What are the things that you'd want to see? And so that led us to making a bunch of changes to the design, to the avatars, so that they were more diverse and inclusive, to make the intervention more engaging. And so I think what's led to the success that we've had, in which we've seen an average of 4 modules, where really the typical average is 1 or fewer. And when people start a module, over 80-something% complete it. It really came from the fact that we built these not sort of in the academic ivory tower and then brought them to the people, but we worked with the people who we were hoping to help and said, what do you need? So again, the sort of work that you're doing so beautifully.
Fantastic. I'm going to start now asking you some of the questions that are coming in. So if I'm looking at the script side, it's because I'm reading something over there. It's not because I'm ignoring either of you two. So Zach, and again, I'm going to ask you to try and keep your answer a little brief on this one so we can get through some of the questions. Somebody's asking, what information would you really like to have inform a personalized intervention? I guess it's a bit like what would be the ideal? So if you could, I can imagine.
The easy answer is the information that we're getting now.
It's enough. Brilliant.
Real-time data about how people are engaging in treatment, how their symptoms are responding, how we're seeing changes in things like rumination and avoidance. That's the sort of stuff that we built this whole system to collect.
So that's the frog system.
Yeah, the rain frog, and also contextual factors. What are the life stressors that you're experiencing? What does your social support look like, right? All those important things that we know matter.
So if I summarize that into 2 areas, there's sort of the things that before they get to the clinician's office, things about the person, their life circumstances is one that you can get readily through various health records or ask somebody. And then there's this really new fantastic thing, which is exactly what we're doing at other stages of medicine, like surgery, seeing what actually happens at the time in the process to try and write that, to get it right at the time. They're the two sorts of things that inform the personalized intervention. Yeah?
Yeah.
Amazing. Okay, great. One for you, Marisa, which is how I think one of the issues that we all know is that many people don't come to mental health treatments, probably the vast majority. And we have one that's come through from the audience, which is just to speak a little bit more, and perhaps you could speak broadly to the field. How do we reach out to those unwilling to connect? Because as clinicians and scientists, it's such a great question, because that's exactly what we all want to do, to include those who perhaps don't have the loudest voice.
Yeah. Yeah, and I think I will zoom out to kind of think about that. So we have, and I think about kids, but we have kids who aren't sharing that they're struggling, or maybe are, but are reticent to engage in interventions and treatment. We have kids who face barriers to even being able to access treatment, even if they are
Yeah.
reaching out. And then we have kids who are receiving interventions and treatment, but are really reticent to engage. So there's a whole range of things to think about in addressing connecting kids to care. And I think, one answer is technology has been quite lovely in terms of addressing some of these barriers from what we were talking about with
Mhm.
Zach's work in terms of, if there isn't a clinician having digital mental health interventions. But also, we've seen in our work that for the kids who are in the hospital but really don't want to be there and aren't interested in talk therapy and aren't interested in um, me as a human coming in and asking them as not just a human, but as like a very old human compared to their 14-year-old self. Um, they're less interested in that, but sometimes when we bring out the VR intervention and they get to do this with an avatar, they're more willing to engage and they're more excited to engage. So I think there is a whole component that technology can be helpful with, but it can't exist on its own, of course. And then the other space I will speak to a little bit, which has been tricky in our work, but I think is really important to acknowledge is, kids are engaging in social media and online search engines and videos not only to connect with others but also to find information and seek help sort of privately. And so I think there's a whole nother line from a universal prevention perspective where we as researchers and mental health professionals really need to be partnering with folks who have an online presence with social media spaces to make sure that we're creating safer online spaces for kids to be able to also access interventions and care and support that way. So I think it's both thinking about kids that we're meeting with already who are reticent and also finding ways to figure out how to distill information, help seeking tips, and even universal prevention kind of skills to kids who might not even be willing to reach out to a person.
And I think your work's a shining example of being able to reach out to those unwilling to connect. And I think maybe in the bigger perspective, there's so much work to be done in that space that we can be encouraged to do, not only for kids, but for adults and for older adults. We've only got a couple more minutes. So, Zach, 30-second answer to how is your work going to be made available to medical institutions and clinicians for implementation? And what I'd like you to just try and explain to audiences what research needs to be done to make it available.
Well, I think the research that needs to be done to make it available falls under the umbrella of what we call dissemination and implementation. So when we create an intervention and take it into the real world, do people actually use it? Are they able to? And if they do they keep using it in the way that we know to be effective? So that's the sort of work that needs to be done to scale it. And my hope is that the intervention that we're developing can be made available to the broad public for free in a way that allows it to be accessible to those who need it.
And that sort of implementation research can take time, just like it does for drug trials. It's not like it happens in a few months. So typically a phase 3 trial might take, I can't remember what the average is, 4 years. So we're talking about research investment, the ability to take these things from now to the clinic. What you can't do is put something straight into a clinic without showing their efficacy. So yeah, brilliant, but you're on that path. It just needs to keep going. Fantastic. Okay. There are so many questions. I don't know what to go to, but maybe one for both of you, just to try and conclude. What, as well as the what do you see as the risks and pitfalls? I think when we do research, all of us as scientists like to think about the ethics of what we do, and we also like to think about the opportunities, which is when ethics it makes it possible to try anyway to do these things. Would you like to speak briefly, either or both of you, on risks and pitfalls as well as why they're worth taking to advance the field and improve clinical care?
That is a hard thing to address briefly. There are a lot of risks and pitfalls, and I think we spent a lot of time talking about how exciting the digital mental health space
Yeah.
is. And I think it's really important to acknowledge that there's a lot of digital mental health interventions, apps, interfaces out there that have not been tested. So I think
Exactly.
that's a
When you
really,
say a lot, isn't it like 99% haven't been tested?
that sounds right. Yeah.
Yeah.
So that, I mean, that's
I
a
mean,
really important pitfall and risk to
yeah,
highlight. But then even within the research space with what we're doing, right? Like we can use technology, it's a tool. We can use technology to facilitate really exciting and improved outcomes, but there are safety risks.
Yes.
In our space in virtual reality. That was the biggest thing that we were trying to assess is this even a safe thing for us to do? So safety was sort of our number one interest and outcome, thinking about cyber sickness from kids putting on the headset, kids with, really complex symptoms that could be exacerbated in a virtual reality headset, right? Like very, very complex
Yeah.
trauma experiences, psychotic symptoms, different things that we wanted to be careful around. So there's so much. And then one more thing I want to say about digital
Okay.
mental
But
health
briefly.
IP, or go ahead.
Yeah.
Oh, is the data protections. Just if you're a
Yes.
clinician or you're a person out there and you're using these digital mental health apps with patients or recommending them, make sure you're really looking at how data is used in those
Yeah.
interventions.
And I think one of the things that's very important to bear in mind is that when we do this kind of work in the context of research, all of it's subject to an ethical protocol where you have to outline and review all of the risks and safety assessments and monitor those as we go along. And again, that's a difference to the big risk that you talked about, which is unregulated treatments and treatments that haven't gone through a research process. And I suppose the whole mental health science field is trying to say, let's put our things through scientific processes rather than go wild. Zach, do you want to say anything else on that? And we're just, I'm being reminded left, right, and center we're at time. So, okay, great. Can I just thank you both tremendously? I wish we could just double the length of this session. But we can't right now, but I hope we have an opportunity to speak again. And it's really kind of you and enormously valued to share your research journeys, the questions that you're answering, and the innovative, scientific-led mental health science solutions that you're pioneering. We're all so proud of the research and very thankful for that at MQ and MQF. And thank you for all that you're doing and sharing with us today. Thanks.
Thank you all for the support.
Yeah, thank you so much for supporting our work.
It's such a pleasure.
Thank you so much, Emily, Marissa, and Zachary for joining us this morning. Really a terrific discussion. Marissa and Zachary, the MQ Foundation is honored to play a role in advancing your work. Your work truly gives us a tangible hope to fight that we can fight against mental illness. And for everybody who's joined us this morning, hearing from today's panel is a powerful reminder of why this work matters. It's easy to feel overwhelmed by the scale of mental illness, but conversations like this show what's possible when science, compassion, and commitment come together. There's so much to be done to achieve long-term change. At the MQ Foundation, we believe progress happens when we all contribute in the ways we can, whether through research, advocacy, or simply by staying engaged in the conversation. If you're interested in learning more about our work or supporting our work, we'd love to continue the conversation. Please reach out to our Executive Director, Ann Richmond, or one of our board members. We'll follow up shortly with an email that will include a link to this recording and Ann's contact details. Ann's information can also be found in the chat. And thank you once again for joining us this morning. We hope you have a great day.